After we saw the ECG, we do interrogations. That means we retrieve the information from the generators. In addition to the post noted in her previous rhythm strip, what other observations regarding the rhythm may be responsible for the patient's symptoms? Because as from the history, we said that this patient has syncopal attack, and she had a chest pain, and besides that, she had a kind of the heart failure. So regarding to these three issues, so there something in the tracing which I displayed a while ago also confirmed this symptom, which I also am going to show to you later on. So what is the final diagnosis? So this is a figure number 2. After the patient does this isometric arm exercise, you see still we have the pulsing here, okay? And here we try to adjust the sensitivity, so we increase it from 2 millivolts to 4 millivolts. And still I do have a pulse over there. That means I did not correct the problem. So I increase it more, I decrease it more by increasing the sensitivity to 8 millivolts, and now I don't have. If you see the rhythm, all of them are the same. I don't have a pulse in between. So the problem is being corrected by adjusting the oversensing, but you see here 8 millivoltage. So hopefully, if I need to, I don't want to create a problem so the device is going to be like under sensing. So what I need to do in these situations, I send the patient to hold a monitor, okay, for 24 hours to ensure that the patient does not develop any kind of under sensing, okay? And besides that, we talk about, you see what this, okay, dinky things here at the end of the QRS. This retrograde P wave. Retrograde P wave usually indicated what? Okay, this patient had the pacemaker syndrome. That means the atrial activity is not occur. Atrial activity does not occur here. So that means this patient had the atrial ventricular dissociation or desynchronization. So in this situation, that is the reason the patient had the symptom of the heart failure. So to correct this, actually, you need to upgrade the pacemaker from VVI to DDD. And before that, we should give, you see, the pharmaceutical management until we just relieving the patient from the chest pain. And after that, we're upgrading the pacemaker to DDD. So here, the final diagnosis, this like ventricular oversensing inhibited the pacing, and the corrections adjusting the sensitivity. And we recommend that due to this symptom of the heart failure, the patients can be upgraded to DDD pacemaker. Case number 2, an asymptomatic 67-year-old woman presented to the pacemaker clinic for her routine follow-up visit. Presented to the pacemaker clinic for her routine follow-up visit. Several years ago, Medtronic single-chamber pulse generator and ventricular lead were implanted for sinus bradycardia and intermittent low-level heart block. During the examination, the ECG shown in figure 1 was recorded. So this, first of all, that's the programming for this pacemaker. Rate is 70. Mode is 7 VVI, 5 voltage, 0.4, 2.5, 325, and the tracing, most likely I will give it to you right now. This is a tracing. We may see this tracing at the beginning when I gave my introduction. I say sometimes being called to the to the units, okay, because the pacemaker does not function. So we may see this type of the tracing. I just going to spend a little bit time for this tracing because that is most what we can see in the pacemakers. When you see this kind of the tracing, okay, so the pacing tracing, usually they do have like a 4 events, guys. Either pacing, or either intrinsic or a native, or either pseudo fusion beat, okay, or either fusion beat, which we cannot see it here. So 4 type of events. So we have here this pacing, and here we have this intrinsic. Here we have, you see, complex number 1, complex number 4 is these are normal intrinsic beats. And you see here complex number 2 and 3, and the last one here is pseudo fusion beat. And number 5 here is a complex of the pacing, contractility, and depolarizations. So in order to distinguish this, so I will come across the questions. So when we have looked and we found the ECG like this, so this patient has intrinsic rate, so and not captured sometimes due to the pseudo fusion beat, and sometimes captured. So here, no problem of this pacemaker. So this is a normal function of the pacemaker. This is a normal function of the pacemakers. So, but if you look here to the intrinsic complex and this pseudo fusion beat, they are similar, but only we do have a spike here. This brings to our attention, so what is a difference between a pseudo fusion beat and fusion beats? So if you look here, the fusion beat, which is not here, but pseudo fusion beat is the same usually, it is a result of the contractility of the native cardiac depolarizations at the time or near the pacing of the output of the generators. In contrast, fusion beat, usually it is a result of the contractility of the native complex simultaneously with the pacing output. So the difference only, the key difference, which I need you to concentrate, the T wave. In the pseudo fusion beat, the T wave is the same as the native. In the fusion beat, it looks the same, but the QRS is different comparing to the capture beats. So here, we don't need to do any corrections. In case if you need to do corrections, we may overriding the pacing, we may pace above the rate, the intrinsic rate, but this is going to deplete the generator because we need more power. But the proper one, so usually we program the pacemaker lower than the intrinsic rate. Okay? I just pass about the questions because I have only 5 minutes more. I like to give them the last case, okay? It's a simple one. Okay, see, have a look to this ECG. Okay, look, please, this, I just give you back the history. So this patient, it has a simple VVI. Okay, during recording, that is a result. Okay, so just concentrate about this. We have the spike everywhere here, but we have a spike and we do have a pause here. Okay, so this pause regarding what? Because we do have a question. Is there marked variation in the pacing cycle interval? So it is not true because we see, usually we see the spike in front of the QRS. Because the question is coming, while a slowing of the rate is often hallmark of a battery depletion, so one would expect to see the marked change in QRS and QT interval in association with the rate slowing. Also, battery depletion is rarely associated with a marked beat-to-beat change in the beat rate. So I just want to read for you the correct answer here. So these guys, it is a recording artifact. So the takeover there, when he takes the ECG, he changed the speed for 25 millimeter per second to 50. So we see this enlargement. So it is not oversensing. It is not like miscaptures, okay? The combination of the rate variation and concordant changes in the QRS and acute intervals suggest a recording system malfunction with the fluctuations in the paper speed. As paper speed increases, the space between consecutive complexes also increases, as does the QRS and QT intervals. I go to the last one. A 40-year-old male patient with an intermittent AV block underwent upgrade of a VVI pacing system to DDD pacing system. 3 hours post-implantation, the ECG shown above was recorded in reflex. This question is the normal pacing. Can I go up? Okay. Sorry. The question is normal pacing system function, atrial lead dislodgement, or a lead discontinuations, or ventricular undersensing. I will going to give you the tracing, atrial oversensing. This is a ECG. So I wonder what is your interpretations. If you, this is a V1 by the way. So you see here, these are the dual chamber upgrading. You see here one spike coming, this QRS doubularizations, one spike here, and we have here also the doubularizations, and we have another morphology here. So what is going on here? So this atrial lead dislodgement, how do we know that? Look to the spike, okay, in front of the onset of the P wave. So it is not coming on the time. And besides here, you see it's wandering. Here we don't have it, and here we don't have it, and here when we have it, it is in the middle of the P wave. Besides that, so this, it is an atrial lead dislodgement. But this patient also, because it's a newly implanted 3 hours. Look here the morphology. So what is your impression about this morphology between, this is a V1 actually. We have here left bundle branch appearance, and here we have a right bundle branch appearance. And again, we have a left bundle branch appearance. So besides the lead dislodgement, we have the lead, the ventricular lead also is penetrated, perforated the septum and went over there to the left ventricle. Because when we pacing the RV, so usually we see right left bundle appearance. But when we pacing the left ventricle, we see right bundle appearance. So this patient had 2 problems. Besides the atrial lead dislodgement, and also has a problems of the ventricular lead is migrated to the left ventricle. Okay, to correct this, so you need to send the patient back to the cath lab and they do the lead adjustment. This is a type of the correction. So just, do I have a time or finished? No time. Okay, so Safia, she said I don't have a time. Really thank you guys for your attentions, and thank you very much.